I think we've got most people into the webinar. Good evening, everyone. My name's Megan Henderson. I'm the Executive Director at NEA in Australia. Before we start tonight's webinar, I would just like to do an acknowledgement of country. I acknowledge that I'm hosting and recording this webinar from the lands of the Eora Nation. I also acknowledge the traditional custodians of the various lands on which you all work today and the Aboriginal and Torres Strait Islander people participating in this webinar. I'd also like to acknowledge the amazing work of our NEA volunteers tonight, especially our leaders. We've had a particularly challenging couple of years and they've really risen to the occasion and helped us keep the Family Connections program running. They've pivoted online and yeah, we're just very, very grateful to everyone that helps us. We're really, really excited tonight to host our webinar for BPD Awareness Week. We have a really amazing panel on tonight to discuss what's the hype about early intervention. NEA Australia is very, very proud to have a partnership with Orygen. The panel will be taking questions at the end of the webinar, so please put them in the chat and we'll go through them and we'll answer as many as we can at the end of the session. I'm now going to hand over to Louise McCutcheon. Louise, I'm going to read this because it's impressive. Louise is a clinical psychologist and is coordinator of the Orygen clinical team and a clinical associate professor with the Centre for Youth Mental Health at the University of Melbourne. She's helped found the award-winning Early Intervention for Personality Disorder program, helping young people early, HYPE, at Orygen over 2 decades ago. She coordinated the HYPE clinical program, has been an investigator in many HYPE research projects, and she established the Service Development Program. Her role currently is to work with services to promote early intervention work in Victoria, nationally and internationally. Thank you so much, and I'm going to hand over to Louise now.
Thank you very much, Megan. I'll just share a few slides with people. So I hope everyone can see that. Does that look all right? Great. So we're going to talk today about what's the hype about early intervention for borderline personality disorder. My role is chair, and we are really excited today because we've got Natasha Swingler, who's a young person with lived experience. We've got Susan Priest, who's a family member with lived experience, and she also works as a family peer worker. We've got Karen Smith, who's the family lead in the HYPE program, and then we've got Andrew Chanen, who's the director of the clinical services at Orygen and personality disorder research. So there are a number of acknowledgements that we would like to make, as well as acknowledging the country on which we are all meeting today, and that those people are all people who have worked in the program or come through the program. So particularly we want to pay our respects really to the young people and the families who've come through the HYPE program, because they've taught us a lot. Just for those people that don't know very much about Orygen, Orygen is Australia's leading youth-focused mental health program. We have a large research and knowledge translation program, and we also have a comprehensive public mental health service, which is where the early intervention program is located. We also have research and knowledge translation parts of the program. We have a catchment area of about 1.3 million people. We cover the north and the west of Melbourne, and that equates to about 300,000 young people between the age of 15 to 25. And so our program is mostly an outpatient program, but we do have inpatient and intensive outreach and also after-hours crisis functions in our team. And so we're going to focus mostly on the early intervention program for personality disorder, which is called HYPE, helping young people early. So I'm not going to talk much more about that. Andrew will talk about that when he's speaking. But this is just to remind you about the program today. We're going to hear first from Natasha Swingler about her experiences of having personality disorder and what that's meant to her. So I'm going to stop sharing now and let Tash take over from here.
Thanks, Louise. Good evening, all. I am Tash. I use she and her pronouns, and I am joining you all this evening from Wurundjeri and Wurrung country down in Victoria. And I would like to acknowledge my elders past and present, and also extend that acknowledgement to any Aboriginal people in the room with us tonight. I'd also like to acknowledge that as I speak to you this evening, I stand on the shoulders of many, many, many thousands of advocates and individuals with lived experience that have come before me, and that have paved the way for these discussions to really be able to involve individuals with a lived experience, both consumers as well as families and carers. I'd also like to stress that any views I share tonight are strictly my own, and that doesn't mean that they will hold true for the entirety of individuals with a lived experience of BPD. But surviving and thriving with BPD, a lived experience perspective. So I think for me, the element of surviving and thriving has really come down to a few elements. Two of the really key ones being having agency and choice in my own care. So personally, it took me many, many years to actually access something that worked for me. When I say many years, I mean probably about 7 years of my 22 years of existence, which may not sound like a lot, but you know, that's a good quarter of my life. Almost close to 3/4 for those of you that can math better than I can, which I assume is all of you. But that meant that, you know, having no options and having no discussion of these options were really challenging. So when I didn't initially respond to the treatments that were offered, I really did internalize that and assume that that meant I wasn't trying, that I was a bad person, that a lot of that stigma that surrounds BPD was really the case, that I was manipulative, that I was just generally an awful person, and that was all my life was ever going to account to. I think for me, I recognize now that that was a lot of self-stigma playing out, particularly from media portrayals of BPD and simply discussions that I heard around me. But when you're not given options, when you don't see a future because of those limited options, these are all things that really played out for myself, and that I've also seen play out in the lives of many young people around myself. Unfortunately, a lack of consistency as well in managing co-occurring mental health issues was incredibly challenging. And it felt like you almost had to pick one thing or the other to manage. As I'm sure all of you can imagine, not helpful. And a lack of clarity regarding medications, crossover in symptoms, and so on also compounded a lot of the confusion, not only for myself, but for my family. But all of these things were ways that I was lacking agency and choice. The flip sides are the ways that things really started to change for me, and I hope to touch on that in a following slide. But I think it's really important to recognize that when we do give young people, as well as people more generally, options, agency, and choice, they're often able to identify what it is that they need and what it is that will suit them best. So whilst we're not all the same, there is enough categorization within our mental health systems without applying that to what is available to each and every individual. Agency and choice is really such a crucial way of taking a step back from how we categorize people and their experiences. So when I refer to those elements of agency and choice, what did and didn't work for me? What did work? The right clinician that really understood and respected that notion of agency and choice, that took the time to be quite curious, non-judgmental, and gentle in their approach, as well as quite harsh isn't the right word, but firm when needed. I'm personally someone that has really responded to DBT, so dialectical behaviour therapy, which has been an incredible game changer on a very personal level. But it was also a lot of the more holistic elements of my care that made massive differences. So finally entering into stable employment, which really helped me with creating a routine, and as a result also avoiding too much free time, and finding supportive and inclusive spaces where I didn't have to pick and choose which parts of my identity were put forward. And at the real core for me of that was having friends that had their own lived experience of complex presentations of different mental health issues. That didn't always have to be personality disorder, but those of us that had experienced personality disorder really seemed to understand the stigma, the self-stigma, a lot of our struggles within the mental health system, and a real drive to see things be done differently and better each and every day. So for me, that led to finding things that I cared about and was passionate about, And at the end of the day, that ended up being working in lived experience systems change and advocacy spaces. Things that really aligned with my own values, my own ethics, things that really made it easy to stay true to myself. And working with DBT, there was definitely a recognition that when things went wrong for me, it was often when I was working outside my own value structures. What didn't work for me? Talking therapies. As I'm sure many of you that overthink can understand, I had already often thought 10 steps further down the track than we could get through in an hour. A lot of medications didn't work, and I think we all can understand that often medication isn't the first line of defense or even helpful for individuals with BPD, as well as repeated changes to my care team, having to continually re-establish all of those networks, boundaries, and comfort levels. Conflict certainly didn't help, but it was something I have thankfully learned to manage, as well as loss of structure and routine. So for myself, early intervention would have meant a lot of things played out very differently in my life. I did lose significant time in year 12 in and out of inpatient admissions. And in VCE, that is incredibly terrifying on an academic level, let alone the lost connections, memories, and opportunities to just be a young person, to have those years that are quite formative. I was incredibly terrified of myself and what I was capable of. And those were awful things for me to sit with, but also for my family, who were honestly quite horrifically watching me self-destruct in front of their own eyes. Early intervention could have meant me not being as terrified of myself and my own capabilities. And it's taken me a long time to get to that point. It had the potential to stop or halt the worsening of my symptoms. And if I had kind of been aware of early intervention, of the different possibilities in my accessing care, I may have been able to enjoy and participate in year 12, be a typical 17-year-old just enjoying life, thinking about schoolies, going to parties, all of that fun stuff that's just normal. Hopefully less, if any, stigma and self-stigma, as well as being able to engage in therapy and make progress quite quickly rather than require repeated inpatient admissions to manage my own safety. I think the really big things for me would be the hope, the potential to hold on to hope throughout those really tough times, as well as the confidence that this would not define myself or my future. And finally, the avenues for change. I think some of the really strong avenues for change in early intervention are the integration of peer work. So having peer workers almost as a first line of defense for individuals with BPD. I think this has incredible potential, particularly when we think about self-stigma. Education and training in relation to self-stigma, both for clinicians and young people. Apologies that these slides say young people quite repeatedly. That's a focus of kind of my interest area and work, but it does apply across the board, as well as an expansion of models of crisis and risk management for people in their homes. So Orygen has a model of care, which is inpatient level care that's delivered to people in their homes, which I think has some interesting potential in that regard to avoid repeated admissions, potential reliance on admissions, as well as incorporating skills for distress tolerance and emotion regulation in the home environment, and remaining with family, home, community to promote engagement within your community supports. Finally, better access to DBT for those who wish to access it, potentially in the future, even integrated with other interventions where applicable to the individual. I'll leave it there so that I don't talk for 3 weeks because I would love to. And I will pass it on to Susan, I believe is next.
Thank you very much. And we'll take some questions if people want to put them in the chat. We'll take them at the end if that's okay. And I'll introduce Susan Priest. She is a family peer support worker at Orygen and has the lived experience of being a carer. She has family peer support, offers support to all family members, carers of young people, both in the inpatient unit and the community clinics. Susan has been involved with the Making Sense of BPD sessions that we have created that were designed for families of young people at Orygen, including being the peer moderator of a moderated online social therapy, called Kindred, which supports families of young people with BPD. She believes passionately in hope and recovery in mental health. Susan, you are very welcome to share your slides if you would like to.
Thank you.
Yeah.
Oops. Hello, everybody, and welcome to the families I notice who are here from Orygen as well. It's great to see some new faces from Orygen joining us tonight. And thank you, Tash, for the insightful comments also about your own family. And tonight I'd like to talk about the families that I've worked with that support a young person with BPD. And often at Orygen, people have actually come to Orygen already having quite a long effort to get support for their young person. And so sometimes they're quite browbeaten, or they've experienced a lot of rejection from services. And so it's very important that when we engage with families, we understand that. It's very well researched that about how families feel. There's no doubt that of how many feel in most areas, carers in mental health, including BPD. Often there's a lot of shock, particularly around issues like self-harm and suicide ideation, suicide attempts, engaging with the psychiatric system, engaging with emergency departments even, can be very shocking and traumatizing for those of us that are carers. And a lot of confusion, and I think Tash was referring to some of the confusion in her own life, and that can also be replicated, I think, with families, that they are looking onto this young person that they love so much, and they're really not understanding what's going on. So I think anger, hopelessness, guilt. Maybe if they'd done things differently, they protected the young person more, something they could have changed when their child was younger, or the person they care about was younger. Maybe it wouldn't have all come to this. There's also some understandable fears about the future, and I think that's normal for families. But some of the grief and loss issues connect into also the fear for the future. So you can often feel the grief leads to loss of, I guess, your aspirations and future hopes for the young person. And that's also quite well documented, that people have hopes and dreams for their young person, and sometimes it all just seems to be out of reach for the family. So social isolation for young people and their families is quite well documented, and often we feel as families constantly worried about how our children are going to fit into society and how we're going to fit in, especially if we've had some very traumatic experiences. And also stigma and self-stigma. Often we've mentioned already the stigma about BPD, but also the stigma of isolating yourself and not being able to talk to friends and family can be quite difficult for people, particularly extended family sometimes, who are often some of our greatest allies and sometimes our greatest critics. The mood swings and the angry outbursts that a person with BPD might have can also be quite tricky. And what families report to me is that they sometimes feel they're walking on eggshells because they're not sure which way to move, how to communicate, what to say so that a young person, they don't have to go to the emergency room that night. So it can be quite a very up and down roller coaster ride. The self-harm and the suicidal thoughts or attempts are very confronting for families, and right across many situations at Orygen, we find that families of, especially with BPD, there seems to be a revolving door with the emergency department, and a feeling that no one really cares, no one really wants to engage with their young person, and take some of the weight off the family's role. The family often have been acting as a de facto case manager for some time, trying to get the support they need. And so there's a lot of it can be very overwhelming when the beautiful child that you've tried to protect all your life and love starts to self-harm, starts to talk about not being here anymore. That's very confronting for families. And one of the things I spend a lot of time with at Orygen is actually talking to families about the 24/7 suicide watch that a lot of them are on, you know, lying in bed with the mobile phone on their chest, having one eye open and one ear open for what's going on with their young person in another room, or maybe waiting for them to come home at night because of the fear of suicidal thoughts. So some of the questions that people ask, some of the fact that carers ask is this normal adolescent behaviour? And what is BPD anyway? They're often quite confused between what is the mental ill health aspect of the person, and that's a very valid question and not one that even clinicians find that easy to tease out. Also, they want to know at Orygen, is my child safe in your care? And I've often say to families, your loved one is safe with us. Doesn't mean we don't make any promises, but they are safe in the fact that we really value them, we really care about them, we really care about you. And often I can see straight away the shoulders drop for the families and a sense of relief, because they've been trying to find safety for so long. That doesn't mean that we can provide that total safety, but it does mean that we care enough to do our very best. Also about, and I mentioned before, about guilt and trauma, and were parents and families often asking themselves, were they a good enough parent? And if you're here tonight as a partner or a friend or a neighbour or someone else, please, I am including you when I'm talking about families, so please, I hope that's okay with you. Communication is another big issue with BPD. People feel like that they're, if they say the wrong thing, that they'll start an argument, that things will all blow out of proportion. So it's really important, I think, that we support families in how to communicate. It's certainly something I wanted to know when I was going through the situation with my loved one, and I think it's something that people can really benefit from. You can't be with the families all the time, but you can give them some skills around communication. So families need flexibility. They need people to be able to be available for them. They need responsiveness from the treating team as well, and that clinicians can actually get back to them in a timely way. That's what I felt anyway, that people would often, the case manager would say to me, call whenever your son talks about suicide, and I would be just calling every day, every half hour virtually. So I think it's very important that that safe place, that treatment team, is actually people who will sit down and respond in a timely way to families' concerns. And that's really time well spent, because when the burden is helped a bit for the relational support and burden is helped with families, often that means that families can relax a bit more and put a little bit more of, I guess, be able to encourage the young person and the treating team to get on with the job of being well and staying well. And I think also people need to be honest about what recovery is, and not overplay the concept of recovery, and talk more about a relational view of how we move forward, rather than, you know, it's 0 to hero and everything's going to be fine, but actually being really honest about the often roller coaster ride that we're on together when we love someone with BPD. Also, this is what I call the seesaw of unknowing. It's this idea, if I push them too hard or I challenge my young person or push back on them, I might make things worse. But then if I don't, then things are really hard at home and I can't have any boundaries. And so this is seesaw of not knowing, you know, do I push or pull on this relationship? And it can be very unpredictable, the behaviours, and a lot of fear in families about if they push too hard, they could drive the young person into doing things that are very scary. But if they don't, they could lose the semblance of what they have at home as a family or as a relation in their other relationships as well. And I just encourage you that I really think the longer I've been in this game, and it's been quite a while now, I really think pacing and timing is everything in BPD and in other mental ill health. That it's really about families learning about BPD, families coming to terms with BPD is a lot about the timing. So not just having the family meeting at the end, or I think it's really important that people are engaged at every level of the journey, because people learn at different times and they engage at different times. And I like to talk about doing the dance with someone who's unwell, and pushing back and testing the resilience of the young person. So the idea is that when they're really, really unwell, yes, you do have to go on the dance floor and hold them super tight. And when they start to show some resilience, some wanting to do some things on their own, some strengths, we start to back off the dance floor. And we will go in and out of the dance floor quite a lot. But the aim is always to letting them go and dancing on their own, then coming back if they want us, if they need us, etc. So it's this moving, it's not the recovery that's onwards and upwards, it's actually this moving feast of push and pull with the young person to see if we can really support them in their recovery. I will just move on, because I just want to mention that I have already mentioned that they're often exhausted by the time they get to us, but I think confidentiality around BPD is really important, and people are very fearful that often those in their community might find out what's really going on in the home, and that leads to a lot of, I guess, not so honest conversations. And so it's very important that we're as open as possible. And that's what's really good about the lived experience workforce, or the peer workers, and that Tash talked about, but also I'm one of those where we can be really so honest with people that this is tough and there'll be really tough times. Also encouraging the family to look after themselves. I know self-care can be a burden sometimes, just saying to people, look after themselves, and the timing of saying that is so important, because often at the beginning, no one wants to hear about self-care because they've got so much going on in their lives. But as time goes on and you build relationships, we build relationships with those families, we can in fact encourage them to step back, look after themselves, and that will pay dividends, not only for them, but maybe for the person who has BPD. Building a supportive team around them, because in the end, it's a lot easier to be on the roller coaster with others than by ourselves. Thanks.
Sorry, you surprised me by finishing abruptly, Susan.
Sorry about that.
That's okay, that's okay. We're next going to hear from Karen Smith. Karen is the lead family worker at Orygen, and Karen is a family therapist and occupational therapist and has worked in youth mental health for 30 years. She's also worked at the Bouverie Centre, where she taught in the Masters of Family Therapy. Karen's role at Orygen is to promote and support the implementation of family inclusive practice within the service, with a particular focus on mentoring clinicians to build the skills and confidence to involve families in client care. Take it away, Karen.
Thank you. Okay. My dog's just decided to come and sit next to me and complain, but hopefully you won't hear her. So I guess when we're talking about early intervention, we're also talking about early intervention in all aspects of care, so including involving families in a young person's care. When a young person's struggling, I guess I'm talking from the young person perspective from Orygen, but when a family member's struggling, all those that care about them are also affected. And the common question is, what is my role? What do I need to do or not do to be helpful? And when you're the parent of somebody struggling, I think that emotional weight's just so much more difficult from the parent perspective. And so family inclusive practice is really about, in a structured and meaningful way, involving family in the young person's care at every point in the process, from very first contact, like Susan was saying, you know, that families need to be involved and informed all throughout the process. and that Fatley and Friends are better able to support young people when they're involved in the treatment and they have an understanding about the nature of the young person's difficulties and what role they can play. So I feel like the common questions that when I meet with parents and families and siblings, the common questions that they ask, and a bit like Tash was saying, often we get people where the BPD has emerged maybe some years ago, and when it initially emerged, family members are trying to make sense of it. And I think that the three common questions are, is there something wrong? You know, is this a mental health issue? Do I need to be supportive? Do I need to be more compassionate? Or is this developmental? Is this them just being a teenager? And are their behaviours related to their attempt to negotiate autonomy? And should I give them more space? Or is this them behaving badly? Are they being insensitive? Are they being selfish? Do I need to start setting boundaries? And if there's a misunderstanding about the nature of the problem, people will inadvertently find themselves responding and acting in ways that aren't helpful either to the young person or their relationship. And I was talking to a mum the other day who, I guess it's maybe 3 years in to their journey, and when we were talking about the nature of the problem and involving her in treatment to setting up a meeting for her and her daughter to talk more about things, she had a lot of regrets. Looking back, sort of feeling, I didn't understand what was going on. I thought she needed space, and a lot of regret. And she was saying, sometimes I was so harsh, I was so angry, and I really regret that. And I guess if families can be involved earlier, there's the unnecessary suffering, a bit like Tash was saying, all the things that she missed out on or that weren't possible earlier. It's the same in relationships, that sort of unnecessary heartache and angst. And this can relate to all family members, you know, siblings. Often it can have a huge impact on sibling relationships where a sibling might get caught up in sort of being protective of a parent or getting angry with their sibling who they think is creating dramas. And again, the earlier in the process we can bring people together to talk about what's going on and how to make sense of it, the more able they are to support the young person. So to do that in a useful and efficient way, I guess, is to have a clear model of family inclusive practice. Most mental health services in Victoria have adopted single session family consultation, which is simply a brief model of family engagement, a meeting between the clinician, the client and the family. So I guess that very much seeking to bring the person affected by BPD and their family together so that they can start to share and talk about their experience and negotiate what they need and what role family can play in helping them recover. And also identify family needs. I think Susan really illustrated that families have their own needs too, so that they can be supported to continue to be a support. So we've adopted single session family consultation at Orygen as a model of family inclusive practice. And I guess just to say one last thing that, here we go. So the pyramid of family care is a really helpful way of conceptualizing the purpose in involving and engaging families. Often when people talk about family meetings or involving families, people start to think it's family therapy, or but the pyramid basically articulates the purpose for meeting. That as Susan was saying, most families really need information about the nature of the problem, whether it's around safety planning, how do I support my family member to stay safe. So most families don't want or need family therapy. Some families may, but the single session family consultation process there's a negotiation where families and young people are asked, well, what are your needs? What level of intervention do you want? For what purpose do you want to meet? And what do you need to know about? So I think I'll try not to, I'll give you a bit of warning. I'm done really with what I wanted to say about, stop share, family inclusive practice.
Thanks, Karen. We'll now hear from Andrew Chanen. Andrew is a consultant psychiatrist and researcher. He's Director of Clinical Programs and Services and Head of Personality Disorder Research at Orygen in Melbourne. He's a professorial fellow at the Centre for Youth Mental Health, the University of Melbourne. Andrew's work focuses on prevention and early intervention for severe mental disorders in young people. He established and directs the Helping Young People Early HYPE program, which is a prevention and early intervention program for severe personality disorder, which has been recognised with several awards for advancing healthcare. Andrew currently receives grant funding from the National Health and Medical Research Council and the Australian Research Council. He has over 170 scientific publications. He serves on several expert mental health groups. He's a past president of the International Society for the Study of Personality Disorders and the recipient of the 2017 Award for Distinguished Achievement in the field of severe personality disorders from the Borderline Personality Disorder Research Centre and Personality Disorder Institute, New York. Now, if that's not a lot of long words, I don't know what is. But Andrew knows a lot about working with young people with personality disorder and their families. So everything he can say in 10 minutes, go for it.
Unmute, so I'll do that. I forgot to unmute, so I'll do that first. And then I'll go back into slide presenter. So thank you to Megan and to the NEABPD for hosting this. It's really wonderful to work with NEA, and they do a wonderful job. Full disclosure, I am on the board, but I think it's important to pay tribute to Megan and the team and the fantastic work that they do. And I'd also like to acknowledge the traditional owners of all the lands on which we're meeting today, and the elders past, present and emerging, and any who might be on the call this evening. So here's what I can say in about 10 minutes. You've heard a little bit about HYPE, and you've heard that we too are standing on the shoulders of many people. While I'm acknowledging people, I want to acknowledge Louise, who's been my partner in this work for 2 decades. So why is early intervention important? Well, principally because it's one of the most common problems seen in psychiatric practice. It's one of the most common mental health problems in the world, actually. Almost 10% of the population actually meet the criteria for having personality disorder. But when you look in psychiatric patients, people attending mental health services, it's up to half of those. And I'm going to use the terms borderline and severe personality disorder interchangeably. And when you look at the more severe forms of personality disorder, it's about 1 in 5 outpatients. So there's a lot of people. In Australia, there are about 250,000 young Australians who have borderline personality disorder. So you can see the scale of the problem, and just shy of 1 million with personality disorder in the adult population. And the significance of this is not just around the diagnosis or the narrow criteria for personality disorder. The reason that we're working in this area is because people with personality disorder have a range of problems that accompany the diagnosis. And the diagnosis is not so important. What's really important is that it's a kind of a red flag for people who are at risk of poor outcomes. And that includes a high burden of mental health problems, severe and persistent problems in functioning in life, poor physical, sexual and reproductive health, being a victim of interpersonal violence, a perpetrator of violent and non-violent offences, and also of having family violence intervention orders. So you can see the range of problems that we're dealing with. Tragically, I think the most telling statistic is that people with severe personality disorder live 2 decades less than the rest of the population, and around about 8 to 10% will suicide, usually within in the first 5 years after diagnosis. And also those who care for people with borderline personality disorder, as you've heard from Susan and from Karen, actually, and from Tash about her own family, really struggle to manage. And this is demonstrated in the research that we've done, particularly with my colleague Sue Cotton, that families of young people with personality disorder have more negative experiences of care, less positive experiences, and really worse problems than even families of young people with a member with first episode psychosis. The trouble is that despite the scale of this problem, most service systems are not fit for purpose for people and families living with personality disorder. And I'm sure there'll be many questions about services around the country. And part of the answer to that is that services are really poorly developed. So normally what we do is what's called late intervention. You heard that from Tash, you've heard it repeatedly, I think, in the accounts this evening so far. The diagnosis is delayed. Usually we offer only highly specialised treatments very late in the course of the disorder to only a few people, and usually those who are willing to attend on a regular basis and are able to organise themselves enough to come to regular appointments. And usually we start treating people when already a lot of the disability is entrenched. And our service systems are very poorly organised. There's limited availability, haphazard access, no coordination, and really a strong focus on hospital presentations. Should they be admitted? Shouldn't they? And an excessive focus on individual psychotherapy as the only form of treatment. And of course, a Medicare type environment doesn't really suit many people, probably most people with BPD. And sadly, particularly in the state-based mental health systems, the service systems are often hostile to people with borderline personality disorder and their families. There's a culture of treatment refusal, bigotry and discrimination are rife, an expectation that patients should fit the treatment, not that the treatment should fit the patients. Families are often blamed and marginalised, and sadly, many people are harmed by the health system. So where should we start? Well, we should start by acknowledging that there is now a large body of research evidence showing that BPD can be diagnosed in young people, that it has its clinical onset around puberty and beyond, and this idea of adolescent personality disorder being somehow different to personality disorder at any other stage in the lifespan is really a nonsense, that in fact it's the same problem, but it presents differently in different developmental phases of life. And importantly, the transition from childhood to adulthood, that particular period of vulnerability, as you heard really eloquently described by Tash, is a period of vulnerability. And if you don't make that transition successfully, then you're set up for difficulties in life. And it happens to be the time when not just BPD, but all of the major mental disorders have their onset. So we can't really talk about borderline personality disorder separately from depression or psychosis or anxiety or other problems. And really early intervention for BPD is a central focus of youth mental health. So what do we look for? We look for, on the left-hand side, you can see that really I think one of the more helpful descriptions of what comprises borderline personality disorder. We look for extreme interpersonal sensitivity, an unstable sense of self, intense and volatile emotions, and impulsive behaviours that are usually self-damaging. These are really lay descriptions of the 9 diagnostic criteria that you can see on the right-hand side. And pretty soon we'll be moving to a different diagnostic system. But those 9 criteria that were made up by a committee sitting around a table seem to describe something that has really stood the test of time in terms of being a predictor of difficulties. And what's the threshold for intervention? Well, we don't wait for people to reach the diagnostic threshold of having a disorder or a diagnosis. Having any of the features of BPD is actually associated with poor quality of life, symptoms, distress, high usage of mental health services, and poor functioning. So again, it's this idea that it's really a ticket to getting into services in order to prevent those poor outcomes. And in fact, the diagnostic features naturally get better in inverted commas over time. What doesn't change is actually the social and vocational impairments, the problems with relationships, education, and employment. And these persist for decades, long after the diagnostic features have gone. And I think this really illustrates the problem. These are Danish data, but they have these fabulous national registries that show that first admission, that is people registered for the first time with BPD, so young people, have a 1/3 lower odds of being in work or education after 9 years compared with any other patient group. And so this is a real predictor of long-standing difficulties in life. But the interpersonal and vocational outcomes are often overshadowed, as Susan really described very clearly, by the focus on self-harm particularly, which is very frightening and often takes a lot of the oxygen. Rightly, you need to focus on that, but it actually prevents people from thinking more long-term or more globally about the kinds of problems that people with BPD face. And the complexity of treatment has really been exaggerated. There's, a lot of discussion about psychotherapy, but, my summary of this is they're like soap powders. They will all get your clothes clean, but they make different claims on the pack. You heard for Tash that DBT was effective and worked for her. There are many other therapies, and what's important is that people have choice and access to treatment to find the one that does suit them. But we were interested to see whether, in fact, psychotherapy is the sine qua non of treatment, whether it is the essential ingredient. And we're just about to publish the findings from this trial. And essentially what we found is that effective early intervention for youth with BPD is not reliant on the availability of these specialist psychotherapies. And actually, all the people in the trial got better, whether they had psychotherapy or not. And what we think are the bedrock elements of treatment are youth-oriented services that offer things like clinical case management and psychiatric care for the co-occurring problems that come along in the kind of package. And the hype service model that we've developed with or without individual psychotherapy was able to achieve greater treatment attendance and completion, making it probably more likely to meet the kind of expectations that service users and family and community members have of care. And so how are we going to respond to personality disorder at a global level? People often ask this question, what's the best psychotherapy? But it's really not the right question. We would argue that the question is, how can we intervene at the scale required by the prevalence of the disorder? How can we help 250,000 young Australians? And how can we fit the health system to the needs of people with personality disorder? So how does this translate into a model of care? Well, I'll just briefly explain how we work. The principles of early intervention are that you should let everybody in. Try and exclude as few people as you can. See personality disorder as a spectrum of severity. Make sure that that's actually the problem, that you're not applying the treatment to the wrong group of young people. Make sure that people know what they're getting, but also if they want to refuse or knock back what you've got to offer, that they know what they're knocking back. And the program is time limited, and it's more than just psychotherapy. And our aims, you can see there's nothing, we don't say BPD in the aims. What we say is the aim is to help people to improve the way they function, the way they live their lives, to reduce mental health problems and distress, to help set them up to be able to get the help that they need in the future, because BPD is associated with a high need for future physical and mental health care, and to enhance their self-care, to get in early to try to prevent problems like, for example, nicotine dependence. The national smoking rate in healthy young people is about 4%, whereas 2/3 of our young people are daily smokers. So you can see that this sets them up for a lifetime of problems. And young people and families should be, and friends should be at the centre of this model. So in order to get in, we make sure that you've got the problems for which the program was designed. We don't exclude people for having antisocial behaviour, substance abuse, whatever it might be. We make sure that we include young people and families, that we focus on their goals. And the program itself is relational, integrative, reflective, and it's collaborative. We do things with people, not to them. And it really has two phases. That the start is the acute phase when people are often quite severely unwell, and then the working phase in which we work on functional goals and the other aims that you've seen. And when people might be offered individual psychotherapy, I don't want you to take away the message that I'm anti-therapy. What we need to think about is what's the place of therapy in the trajectory of people's care. We use a particular form of therapy called cognitive analytic therapy, and we combine clinical case management, individual therapy, and psychiatric and medical care, all in the one package, in the one team. And you can see that there's a range of people who contribute to the overall care of the young person and their family. Our main aim with medication, and there might be questions about this, is to reduce or prevent inappropriate or harmful prescribing. As I think Tash might have mentioned at the beginning, there is no medication for borderline personality disorder, but actually the majority of people with BPD are prescribed medication, often inappropriately. We will treat other problems as well. So people often come with depression or anxiety, and people get stingy about the treatments for those kinds of problems and don't address them adequately. So to conclude, BPD has its clinical onset between puberty and young adulthood. There's a high potential to disrupt the successful transition to adulthood. And you can see, I think Tash's description was much better than those lines about, you want to get to the school formal, you want to be able to form relationships in a social group, you want your family to be thriving when you move into adulthood. There's strong evidence to support early detection and intervention, and integration is needed with global endeavours to prevent the onset or the continuity of mental health problems in young people. Treatment is more than individual therapy, and early intervention is likely to be effective if it includes a model of BPD, youth-oriented clinical case management and psychiatric care, and the HYPE program is scalable across health systems and can be integrated with early intervention across the range of severe mental health problems. So I hope I stuck to my 10 minutes, and I'd be happy to join the panel to take some questions. So thank you for listening.
Great, thank you, Andrew. I've been putting together some of the questions and thinking how we can try and cover the spread of them. So there were a number of people who put in some acknowledgements and thank you. So I'd like to say that first, they particularly wanted to thank the people who had shared their lived experience. I think that's really important that we acknowledge the importance of that, and hearing really from people about their personal stories is actually really important. Tash, there was a question for you, which I wonder whether you would like to go first. And that was, would you mind sharing the top things you would have wanted or needed to hear on first getting a diagnosis? And maybe while you're doing that, I can put some other questions together.
Oh, thanks, Louise. I think the real key things for me would have been understanding this isn't a death sentence and this doesn't define me or my future. I think when you hear that label, that there is something inherently wrong with who you are, because it's your personality, right, that someone is saying is wrong. That's what it feels like. Mm. Your expectations for what your future holds are dramatically lower. Your expectations of what you think others around you think of you or expect for you drastically change. So I think for me, it would have been an understanding that this didn't define me, it didn't define my future, that people didn't have to see me as any less. I was still as much as a human as anyone else. I just needed a little bit of a help with some elements of the ways I was coping with distress.
Yeah, that's lovely. I wonder if any of the other panel members want to say anything about stigma and labels, given that there are probably other questions about that.
Can I just say that I think families want a lot of what Tash just said too. Less stigma, perhaps some normality, not being put in a pigeonhole because their loved one has BPD. So I think there's a lot of that, I guess, the normalizing or the acceptance of the family members so they can move forward and feel that they are part of the community. So I think, I think there's a common sort of cry, really.
Yeah.
I might just add that I think that it's important to recognise a lot of the stigma and the negative kind of attitudes about BPD actually come from professionals and sadly from our peers. And that there is this whole debate about the name and the concept of personality disorder. And I think that clinicians, particularly in the past, have not done a service to this by promulgating these negative attitudes. And frankly, at times it's just bigotry. And I think that we need to address that in the professional community, and not, people should not put up with that kind of treatment or those attitudes. And then it becomes about, holding on to hope, about giving the dual messages that this is a serious problem, but as Tash said, it's not a life sentence. It's a problem that with some help, you can live a valuable and meaningful life that you want to live. But it does require some support. And without that support, the chances of difficult.
You just got cut off then, Andrew. Do you want to do the
I?
last little bit of what you just said then?
It was my best 10 words I ever said.
Yeah, it was.
I was just saying that it's important to recognise that it's not a life sentence, as Tash said, and that we can both simultaneously recognise that this is a high risk kind of situation, but hold on to the hope that that change is possible and even likely with the help that we can provide.
Great, thank you. There were some questions about early diagnosis, and I just wondered whether you would clarify some of those. So what's the age, what age is considered early intervention? And do you want to just comment on perhaps the issue about diagnosing under the age of 18? People say
so it still kind of keeps coming up, even though the science has really been settled on this for a very long time. That it's the same problem in young people as it is in adults. The analogy I often use, it's a bit like asthma. You can diagnose asthma at any age, but it presents differently in children or in adults. But it's the same kind of process underneath that unifies it. And there is a myth that still is very hard to kind of tackle among some clinicians, that somehow you're not allowed to diagnose personality disorder in someone under the age of 18. That's just simply not true. It never was true. In fact, it's a misinterpretation, but it's a strongly held cultural belief among clinicians. So clinically, mostly you can recognise it from around puberty, but actually when you trace the kind of roots of it, you can often trace them back to childhood. We usually recognise it as a kind of clinical diagnosis from around about puberty. And if you're going to develop the problems, they're between puberty and about the mid-20s.
That's great, thank you. There were some questions about how family members might encourage the service to include them a bit more. So there was several people who described different sorts of experience of feeling like privacy and confidentiality were used as ways to keep them out, and maybe the there might be other people who were experiencing, maybe the young person doesn't want them involved. But I wondered if maybe Susan and then Karen could comment on that, how family members could deal with that and try and resolve that.
I think that the privacy and confidentiality issue has been overblown, partly by services. And I think at least at Orygen and the people that I know that work there have had a very, I guess I call it a massaging technique in privacy and confidentiality, that we work with the young person and the family to see how much communication we can get between the service, the young person, and the family members. And so and if that's not apparent and available right now, then it might be in a few months' time. It might be next week. So we don't stop talking about it. Whereas my experience in the adult sector, adult public health sector in Victoria, was that sometimes the shutter comes down and it's called privacy and confidentiality. And a lot of clinicians can use that as a way of, well, we've asked that question, let's move on and we'll just work with the person who's unwell. So I think it's really is a revisiting and a massaging of the relationship on all three fronts that can bring that real communication. And that's been my experience. I think it's a really useful way of going forward. Karen?
I guess what I'd say is we've just had a Royal Commission into mental health, and one of the outcomes is that families need to be included more. They need to be provided with information in order to have a caring role. So there's lots of policy frameworks that endorse family inclusion, but at a local level, again, I think having a model, or so if you've got, I think I read one of the chats where somebody had a young person who was seeing somebody and they were told they couldn't have any information because of privacy. I think sometimes it's just really clarifying what exactly you need to know and for what purpose, rather than a blanket privacy. Often young people don't mind if general information is shared, or so I think, don't give up, maybe reach out to the practitioner, talk about family inclusive practice. You don't want to know their private personal issues that they're talking about, but it would be good to have a better understanding about what is the diagnosis, what is the treatment, what as a family, could you tell us so that we can better help them. But the single session family consultation model really starts with the young person or the client, where the clinician speaks to them around, well, in what way might we involve your family and for what purpose? And often there's a benefit to the person affected. If my family could better understand, they would know what I need, or we could negotiate in these particular moments. So I think just understanding what the purpose is and the nature of the information that you want to share and talk about.
Can I just add to that, Karen, too, that I think that family, sadly, I think wherever you are at the moment, in Australia, maybe in the world, family members and loved ones and the people who the young person sees as their advocates will still have to be advocates, I think, in this point in history. We still need people to stand alongside a young person, particularly who's got BPD, and fight for them in many cases. And you will become, again, sometimes the de facto case manager, because a lot of services are not set up to provide that safety that I was talking about before. So if you are a family member out there tonight, stay with it and keep advocating until you get the answers that your young person needs and that you need.
Great, thank you. There are obviously many more questions than we're going to be able to answer tonight, and I think we've probably already overdone the time a little bit. I'm going to suggest that we go till 8:45. That gives us another 5 or 6 minutes to try and answer a couple more questions. If people need to leave, we understand. We've already probably gone over the time that we actually said we would. So there's a couple more areas that there are lots of questions around, and one of those is about accessing treatment, and particularly for people outside of the Orygen catchment area. There are lots of questions about that. Not only are there services available to people under 18 and over 18, but also how would they advocate for similar sorts of services? And someone has suggested, would it be possible to for headspaces to offer this kind of service? So I was wondering, Andrew, whether you had some thoughts, and I don't know whether Natasha might have some thoughts about that as well, or anyone else.
So that's a really important question, because Headspace is a fantastic platform to be able to deliver services to young people. And the trial that I mentioned, the MOBI trial that we're just about to publish, actually one of the arms took place in one of the Headspace centres, but it wasn't Headspace care. It was one of the problems with the Headspace model for people with BPD is that it's mostly private practitioners providing fee-for-service treatment. And that doesn't always, it suits some people, but it doesn't suit everybody. And particularly for early intervention purposes, what we think is that the model that we've developed is translatable to the Headspace platforms, but it's not a complex model, but it needs people who are salaried to be able to deliver it, because people don't turn up. They need people to go and see them at home. They need intensive treatment one week and not too much the next. And so to have that flexibility, it can't just survive on a fee-for-service model. And it also needs team-based care as well. And so teams aren't really easily funded by a Medicare type model. So we're very hopeful that Headspace can provide a platform, a national platform for early intervention. Tash, did you want to add anything?
I wish I had a really simple and brilliant answer for this one. Unfortunately, I think all I can really say is keep trying. Eventually you do find someone that clicks and does make all of the difference. Sometimes it's the relationship more than the intervention itself.
Yeah.
Can I just comment on that too, because I think it's a really important message, but it's also for people listening this evening. One of the difficulties with awareness raising exercises like this is that you just make more people attend a broken system and get demoralized. And so all the questions about where can I find services are limited. It is no doubt tricky to navigate the system to find services, but I think Tasha's point is really important. Keep trying, because it is easy to give up and easy to get demoralized when you try to find help. I field so many emails and calls every week from people desperately trying to find services, and I always encourage them or their families to keep advocating to find services and keep pushing. You can always contact Louise or myself as well. We often help people to guide them towards services both nationally and internationally. So we're happy to help them to try to find services as well.
And I think there's another thing that I would just quickly add, and that is that the Australian guidelines about how to care for people with BPD very clearly say that diagnosis is not something that should exclude people from mental health care. So we should be able to negotiate some care wherever you live and whatever service you're trying to get care from. And so it is about not giving up. It's also not about giving up if the person that is struggling with those problems isn't ready for care at that moment. I would also be saying to family members who are experiencing pushback from the loved one who's struggling, if it's not the right time for them, maybe it's not the right time, but that doesn't mean it will never be the right time. So I would also keep it in mind that person might change their mind at some later date, and it might be, when it looks different to them, and when they're not feeling so stigmatized, or when they feel like whatever the treatment is looks different from the last thing they tried, and it might be worth trying things. Tash told us a good story about how the first lot of treatment wasn't so helpful and the second lot was. So it's really important to not give up. There's finally quite a number of questions about how does BPD emerge, and what is it to do with? Are you born with it? Is it something along the lines of neurodiversity? I know that's a huge question, but I wonder if there's sort of something fairly simple that you might be able to say, and perhaps we could direct people back to some of the resources that are on our website and things like that, which might explain those issues a little bit more clearly. And then I think...
Do you want me to tackle that one?
Yeah, probably.
Yeah. So it's a combination of nature and nurture. It is not destiny or inevitability that people develop BPD, but it is a heritable problem. So it does tend to run in families. But again, that's like inheriting a sort of a switch that might be switched on or might not. And the kinds of things that that can switch it on include some sort of biological processes, but also difficulties in the environment, the kind of fit between that young person and their environment. And it's really the emergence of the problem is a sort of a reciprocal process between the young person and the way they're built and the environment in which they find themselves. And for some people, that can mean that they develop clinical problems. And that, I mean, that's a fairly, simplistic explanation of it, but I think it kind of captures the guts of what's going on here, that you're not born with it, and it's not all the fault of families, who raised the young person. And it is about the interaction. I saw one question about, families being blamed because of the issue of trauma. And it's clear there are multiple pathways to develop BPD. About nearly a third of people with BPD don't report any traumatic experiences on the pathway to BPD, but about 2/3 do. And so there are different ways to end up at the same point. And it's important that we recognise all those pathways and that we understand each individual and how they got there, and that the plan to work with that young person and the family is developed based on their story, not on a generic understanding of the disorder, or particularly the kind of stigmatizing beliefs that we talked about earlier.
Okay, I think that we really should finish up now, otherwise we'll be talking for another 10 hours probably. So I would like to thank all the speakers and thank Megan and her team. And is there anything else that you want to say, Megan, just in the way of finishing up?
Yeah, first of all, I just want to thank the team at Orygen, Natasha, Susan, Karen, Louise and Andrew. It's been fantastic. And I think the feedback and the comments we've had, it's definitely been worthwhile, and we really appreciate your time. I just wanted to add, for those who are not familiar with NEA and maybe our Family Connections program, so NEA really does exist to support family members, and we have an evidence-based 12-week program that we offer free of charge to families all across Australia. So if you haven't already registered, feel free to do that, and we'll try and get a program to you, and that might provide some relief or some skills and hope for you to help support your loved one.
And I've put a link in the chat to the Orygen website, which has a lot of downloadable and accessible resources. So most of them are free. So
yep,
feel free to go and look.